So next into this is what are the various conditions in which it can be used. There are other diseases. We shall skip them very fast because already we have gone through various important conditions. These are the rare occasions. These are very small one, but we'll do it fast. So one is sarcoidosis. Sarcoidosis is a condition where abnormal inflammatory cells are present in one or other tissue. It can be present in any tissue, but if it is present in heart, then it will cause cardiac arrhythmias. This can be very severe and can result into sudden cardiac arrest. So if it is the arrest condition, then we have to give for this implantable cardiac defibrillators are there. As I told you, these are ICDs, or these devices are there, which are automatic devices. They are implanted, and these are regulating the heart rate rhythm on the machine. They are sending impulses and they are sending shocks accordingly. So if it is useful, fine, then that is the treatment. If it is recurrent arrhythmias and inflammation is there, then go for immunosuppression in addition to that. If this person is not an ICD candidate, because it can be depending on that many condition, including if the person has got some life, or if it is very aged one, then this is too expensive and it needs too much care. So in that cases it cannot be installed. So we cannot say that it is a ICD candidate. So it will be depending on the functional status, life expectancy, patient preference on that basis. So if the patient is actual candidate, then it can be given. If no, then other symptomatic treatment, or we call it as a guideline directed management of and therapy is given. So as per the guidelines, whatsoever antiarrhythmic treatment is given. If it is there is no such cardiac arrest and left ventricular ejection fraction is less than 35%, if there is yes, it is less than that, then again go for ICD and treatment as a previous one. But if it is no, if it is better one, some other activities are there, and check whether the person is ICD candidate. So in most of the cases, we need the implantable this cardiac defibrillator devices, and accordingly that can be the treatment. So when there is a heart failure simultaneously with rejection fraction, then go for various tests. Go for left ventricular assist devices. We call it as a left ventricular assisted devices, and check whether and simultaneously this implantable this cardioversion devices are there. Try to go give it. ICDs can be used after heart transplantation. You can use this in the patient with heart transplant and severe allograft vasculopathy because of the new tissue is there, and the rejection chances are there, left ventricular dysfunction is there. ICD can be given for when the survival is expected to be greater than 1 year. If it is less, then no need to make expenses on that. In case of neuromuscular devices, again ICDs can be given, and when the survival chances are greater than 1 year, then the patient with other type of that is Emery Dreifuss will not go for each and every, but yes, in most of the cases we say that ICD can be given. And the most important thing in ICD is very important thing is the patient selection. Patient should be good candidate of it. Why good candidate? Because patient should be having sufficient age, chances of working, then should be able to tolerate, then only it will become an ideal candidate who can bear all these expenses, and there is some positive outcome of it, then it can become that, and thus it will be important candidate selection, or whether patient is ideal candidate or not. Then cardiac channelopathies, we know there are channels are there through which the impulses are passing, and when these channels are damaged, then we see that arrhythmias are there. We have seen it Mandelbrot or circulatory or circuit type of arrhythmias. So in that cases, in the various arrhythmias, what kind of arrhythmias are there, whether there is a channelopathy or there, ICD is recommended in all cases when it is meaningful year of is expected. Specific cardiac channelopathy symptoms are there, there are some congenital problem are there. In that also ICD can be recommended. Then next is specific cardiac channelopathy syndrome, again congenital long QT syndrome. In that this patient having long QT syndrome, recurrent appropriate ICD shocks are there despite of maximum tolerated doses of beta blocker. So additionally, intensification of medical therapy with additional medication can be given, or then the other activity like cardiac sympathetic denervation can be done. But these are again at very severe cases, these are all there, because ICD itself is we are considering at a very high situation which is very difficult to otherwise treat. In that cases we are going for it. The patients with suspected long Q2 syndrome, ambulatory ECG monitoring is required. Monitor with ECG and check it, because Q2 syndrome is dangerous. Then next is the patient with long QT syndrome, QT prolonging medication, any drug which causes QT prolonging. If you remember, our antiarrhythmic agents which are causing QT prolongation should not be given. They can be very harmful because already QT is long. So these are various agents which can be given. There is a long QT syndrome is there, and this we are having problem. We are having there were what we can say cardiac arrest. Because of cardiac arrest, we have done the cardiac resuscitation, or CPR, we have some cardiopulmonary resuscitation we have done. So the patient which were resuscitated from the cardiac arrest, which are survived, then the beta blocker is the best recommendation. Go for beta blocker, and then if it is a candidate, go for ICD, that is intracardiac defibrillator devices, go for this. But if this long QT syndrome was there, then in that cases QTC which was less than 470 ms and QTC was greater than 470 ms, these two categories we can make. Then in both cases we are going to use beta blockers. Then if there are still persistent symptoms and the patient is at high risk, then go for ICD. And in other cases also, whatsoever is there, treatment intensification, cardiac sympathetic denervation, and then lastly as a ICD. So these are the final treatment which are there. There are various drugs which can cause QT prolonging, or hypokalemia, hypomagnesemia, and this drug has to be avoided. They are very harmful in this nature or in this condition. Then specific channelopathy symptoms are there, where catecholaminergic polymorphic ventricular tachycardia is there. That means there is an increase in the catecholaminergic release or sympathetic activation, or we can say that is the cardiac accelerator nerve, it is many times called, which is coming from cardiovascular center of medulla oblongata. This will have more activity, and this more activity can result into this arrhythmias, ventricular tachycardias and ventricular forceful contractions. So in that cases beta blockers are recommended, because we know that beta blockers are how they are functioning. In that this polymorphic ventricular tachycardia and recurrent sustained ventricular tachycardia or syncope, when we are giving maximum tolerated beta blocker, treatment intensification can be done with other drugs, or ICD can be recommended when other drugs cannot be used. The patient with catecholaminergic polymorphic ventricular tachycardia with clinical ventricular tachycardia, genetic counseling and genetic testing are done, whether it is because of the genetic reason, and then accordingly we can go for that line of action. Cardiac channelopathy, there is one specific named syndrome, we call it as a Brugada syndrome. So in that case, if the asymptomatic patient, only type 1 Brugada ECG pattern are there, observation without therapy is recommended. But if there are sign symptoms are there which are showing cardiac arrest like or ventricular arrhythmias or syncope is there, then for that ICD is recommended for a meaningful survival of greater than 1 year. And if still there, it is not making there are shocks are there, in that cases go for quinidine or catheter ablation is there. Quinidine we are using in very rare occasion, if you remember, or you can see. This is first time we are finding quinidine is being used. Otherwise, in our pharmacology, quinidine came as a class 1 drug in very early situation. So here it is reserved because it has got more adverse effect comparatively. So it is compared with what either quinidine or catheter ablation is used. Catheter ablation, I told you what is catheter. Catheter is pushed to that area from where more impulses are coming, and that tissue is destroyed by various means, either by heat or by too much cool chilling effect or by surgical removal. But that portion is removed, and this is called as a catheter ablation. Specific again in that Brugada syndrome, a patient with spontaneous type 1 Brugada ECG pattern symptomatic. Again, we have seen that there are not candidate for or decline on ICD quinidine. Catheter ablation is recommended. So ablation is only thing is done in that. A patient with suspected Brugada syndrome in the absence of spontaneous type 1 Brugada ECG. Then gives sodium channel blocker can be useful for the diagnosis. So we will not go for this type 2 recommendation or class 2 recommendations, because they are not very common, they are not very important one. Then next in that case is prevention of sudden cardiac death patient with Brugada syndrome. So this is how we are done, or what's the discussion we had. So it has found that there is a Brugada syndrome type of genetic problem, and the ECG is showing there are two things. There is we have done genotyping, we are checking the genetic information of the patient and go for genetic counseling. Then there are suspected Brugada syndrome, suspected Brugada syndrome. So these are the suspected one. In that cases, what we can do is go for various pharmacological treatment. If there is cardiac arrest, recent unexplained, go for if the person is ICD candidate, then ICD is the better choice. If no, then whatsoever quinidine and catheter ablation can be given. We have seen this. Then if cardiac arrest recently experienced syncope is not there, then observe without therapy, check it out if it is not dangerous one, and if it is there, find out the study whether there are chances of growth of it. So this is how we are going for this Brugada syndrome. Cardiac channelopathy, we call it as a J-wave syndrome. Again, check it, asymptomatic, observation without treatment is okay. If the patient with early repolarization pattern of ECG or cardiac arrest, then ICD is recommended. When the early repolarization pattern on ECG is there, genetic testing is not recommended. Then specific cardio channelopathy is there, short QT syndrome is there, asymptomatic patient with short QT interval is there, check it. In patient with short QT syndrome, we have cardiac arrest or sustained ventricular arrhythmias, ICD is recommended. Again, the patient should have minimum survival year of greater than 1 year, then it is useful, then the cost has some meaning. And there are other class 2 recommendations, and which are having comparatively lesser level. What will be happen if this were structurally or functionally some abnormality is there? What will happen if there is a ventricular arrhythmia in structurally normal heart? Heart is structurally normal, still it is showing, then what we should do in that case? So patient have symptomatic this paroxysmal ventricular arrhythmias or tachycardias, in which otherwise normal heart treatment is there. In that cases, this calcium channel blocker is useful to reduce recurrent arrhythmias and improve these symptoms. Patient having symptomatic ventricular arrhythmias and otherwise normal heart treatment with antiarrhythmic medication is reasonable to reduce it. We know what it is. We are trying for two types of important medications. These are beta blocker and non-dietopyridine calcium channel blockers, they are if they are not effective, then go for other treatment. The first treatment is this. Let us see what is treatment outflow we can have. Patient with symptomatic outflow tract ventricular arrhythmias with otherwise normal heart, for whom the antiarrhythmic medications are ineffective, not tolerated, or not in the patient preference, catheter ablation is useful. Catheter ablation I already told, that is removal of that part with catheter. So the patient having symptomatic outflow tract ventricular tachyarrhythmias in an otherwise normal heart, beta blocker, calcium channel blocker, they are useful. Then papillary muscles ventricular arrhythmias are there. So let us see what it is. If this is symptomatic arrhythmias are arising from the papillary muscles, so and antiarrhythmic medications are ineffective in that, or they are not tolerated or not in the patient preference, then catheter ablation can be done. Then infravascular reentrant, there is a reentrant mechanism. In that cases, what we can do is, patient with verapamil sensitive idiopathic LVT related, that give verapamil, otherwise give catheter ablation. Patient with sustained hemodynamically tolerate verapamil sensitive idiopathic LVT related to intravascular reentry, intravenous verapamil is the most better treatment. So in all cases, verapamil is the best treatment. In young patient less than 40 years and having this unexplained this sudden cardiac arrest, unexplained near drowning or recurrent exertional syncope, who do not have ischemic or other structural heart diseases, then genetic arrhythmia chances are to be checked. They can be evaluated for genetics, whether they were having any genetic condition by which it is there. The patients having resuscitated from sudden cardiac arrest due to idiopathic polymorphic ventricular tachyarrhythmias, ventricular fibrillation, ICD is recommended. Then this management of patient with ventricular arrhythmias and prevention of sudden cardiac arrest, what we can do in that case. So in case of cardiac arrhythmias which are induced, so in that cases what we shall be doing is, generally this arrhythmia separation for symptoms which are declining the ventricular function suspected because of this ventricular changes, generally so these are due to these premature ventricular complexes are there. PVCs means preventricular complexes, premature ventricular complexes. So if these are there, that is 15% of beat are predominantly of one morphology, and in that cases the medications are ineffective or they are not tolerated, then catheter ablation is done. But again, the first preference should be medications. Patient with this cardiomyopathy, pharmacological treatment like beta blocker, amiodarone is reasonable to reduce the arrhythmias. Then next is ventricular arrhythmia and sudden cardiac death related to specific population. So in cases, what we can do in pregnancy with long QT syndrome, beta blocker should be continued during pregnancy and throughout the postpartum, that is after delivery it should be done. In the pregnant patient with sustained ventricular arrhythmias, electrical cardioversion is safe, effective, and should be used with standard electrode configurations. It won't make any problem, and it will be safer than drugs. In pregnant patients which need an ICD or ventricular ablation, it is reasonable to undergo this procedure, and particularly first trimester it can be done. After that, as it will be going higher one, it will not recommend it. If the patients are geriatric patients, in that those which are having significant comorbidity and meet indication primary ICD, and ICD is reasonable if they are expected to survive beyond 1 more year after this. Then digoxin, how it can be, that is medication induced arrhythmia. We have seen, and I told you during pharmacology, that digoxin is such a thing that it is used in arrhythmias. We have seen earlier that it can be used in atrial arrhythmias in earlier classes, but it can cause ventricular arrhythmias, so it is very difficult one. It is one of the drug of choice in last stage, that is maybe stage 3, stage 4, or grade C or D type of heart failure. In that these are used, digoxin is used in heart failure, we have seen. So this digoxin is responsible for causing arrhythmias. So administration of digoxin antibodies are recommended patient who present with sustained ventricular arrhythmias due to digoxin toxicity. If the patient with recurrent or SCD points, which is associated with acquired QT prolongation and bradycardia that cannot be suppressed with intravenous magnesium administration, and increase in the heart rate with atrial or ventricular pacing or isoproterenol are recommended to suppress the arrhythmias. Then a patient with QT prolongation due to medications, hypokalemia, hypomagnesia, or other acquired factors should be checked. Then recurrent or SCD points should be checked, and administration of intravenous magnesium sulfate is recommended to suppress the arrhythmia. Then next is medication which are causing QT prolongation and torsid D points. This is again, torsid D points is one of the condition which causes the arrhythmia like situation, and this is particularly the peaks are getting twisting, a specific type of heart rhythm that can lead to sudden cardiac death. So this is a very typical one. It causes ventricular arrhythmias, and it is polymorphic ventricular tachyarrhythmias which subsequently begins to make the ventricular fibrillations. So it is very problematic one, and this ECG patterns, they show that there is this ventricular arrhythmia pattern. It is resembling torsid D points. So where it is there, which is associated with the acquired QT prolongation, potassium replenation to 4 millimole per liter or more, and magnesium repletion to normal values are beneficial. Sodium channel blocker related toxicity can be there. Patient taking sodium channel blocker, you know what are sodium channel blocker. All class A drugs are sodium channel blocker. If you have classified them, or you have studied them earlier during pharmacology, so all the drugs which are in class 1A, class 1B, class 1C, all are sodium channel blocker. These are present with elevated defibrillation or pacing threshold. Discontinuation of this medication or reprogramming the device can be useful to make the effective device therapy. So this defibrillator can many times be having set with a higher current, that can also be reduced. Patient with congenital or acquired QT syndrome, QT prolonging medication are potentially harmful. Then next is congenital heart disease. Go for checking genetic situation, what kind of genetic makeup is there, and what kind of problems are there. Accordingly go for this, and if treatment is not useful, then go for ICDs. It is a recommended one, and every time when we are recommending ICD, every time it has to be seen that there should be life expectancy should be at least 1 year, or the disease should not be in progressing form that after fitting ICD the patient will die within 2-3 months. So it won't be much beneficial in that patients. Then in acute adult congenital heart diseases, patient with adult diseases with sudden cardiac arrest chances due to ventricular tachyarrhythmias or ventricular fibrillation, and there is no such cause which can be reversed or which can be changed. Example, there are drug induced, and if we change the drug or we stop the drug, then it should be reversible. So in all cases, in such cases, ICD is recommended. Then in various situations where high risk characteristic and frequent ventricular arrhythmias are there, the electrophysiological studies should be done to evaluate the reason behind it. And in patient with adult congenital heart diseases, we can have ventricular tachyarrhythmias or recurrent ICD strokes for ventricular tachycardias. Catheter ablation can also be effective. Then next is other recommendations, which are class of recommendation is 2 and 2A or 2B. So what are they? Beta blocker can be added or other drugs are added which should be helpful. Then ICD is again best treatment. Patient having adult congenital heart disease, severe ventricular dysfunction is there, left ventricular ejection fraction is less than 35%, and symptom of the heart failures are there despite of this guideline derived this therapy is there, management or therapy is there. Then ICD implantation should be done. Patient with adult congenital heart disease who have asymptomatic ventricular arrhythmia, prophylactic antiarrhythmic therapy with class 1C medication like flecainide, propafenone or amiodarone is potentially harmful, and it should not be given in congenital disease. So this is how we have got the algorithm charts. If there is a congenital heart disease, then what we should check, we'll go for evaluation, we'll check what kind of activities are there. In most of the cases, we are going for ICD if the patient has or is a good candidate for that. Okay. If the still this recurrent after ICD also it is there, then we have two things: either we'll go for catheter ablation of that particular portion, or we can just set the ICD again. And if the adults are there which are having this torsidy points and all situations, then can go for beta blocker for that. So these are various conditions in which we can go for these drugs where ICD is recommended, where it is there. Now what are various kind of defibrillators which are available? Most common are there, that is known as a transvenous ICDs, that is implantable, which can be implanted near heart, and that will be remain in their area for a long period of time. So usually patient who meet the criteria for an ICD, who have an adequate vascular access or at high risk of infection, and the pacing of bradycardia or ventricular termination is neither needed anticipation, subcutaneous implantable cardioverter is recommended. In that, then instead of implantable we can go for subcutaneous where we have got a problem. Patient who meet indication for ICD, implantation of subcutaneous implantable cardioverter defibrillator is reasonable if pacing for bradycardia or ventricular termination. Part of CRT is neither needed or not anticipated. So these are conditions how we can use these agents. There are some, we call them as a wearable cardioverter defibrillators. So these are patient with recommendation of ICD and history of sudden cardiac arrest or sudden ventricular arrhythmias, in whom removal of ICD is required because of infection or some other reasons. Then we can give them a wearable cardiovascular defibrillator. It is reasonable for prevention of sudden cardiac death after this cardiac arrest. Patients which are having increased risk of sudden cardiac death but who are not ineligible for means who are eligible for, in brief we can say, those which are eligible for these implantable cardioverter devices like awaiting cardiac transplant, having left ejection fraction of less than 35% and within 40 years of the age, particularly had a myocardial infarction, have newly diagnosed non-ischemic cardiomyopathy, whatsoever reason it may be there, So in that cases we can use variable cardioverter till the person is fit for or is getting heart for implantation. Then there are special considerations for catheter ablation. So in certain cases we have seen that we can go for catheter ablation. I repeat what catheter ablation is. That is, we put the catheter just like in angiography. On angioplasty we have seen that catheter reaches to that particular area. Accordingly, catheter will reach to that area, and from that area it will pass through the major vein and the arteries from the thigh, and from this artery it will go to major aorta to these coronary arteries, and from this coronary artery it will reach to area, and for that area this some of the portion will be either removed surgically. This is called as a catheter ablation treatment. So these are used in the patient with the bundle branch reentrant ventricular tachycardias. Catheter ablation is useful for reducing the risk of recurrent ventricular tachycardias and shocks which are there because of the ICDs. It is one of the important recommendation, or it is class 1. Patient with structural heart diseases who have failed endocardial catheter ablation. Epicardial catheter ablation can also be done in that for reducing the risk of recurrent monomorphic ventricular tachycardias. We have nothing to do with this postmortem. Terminal care, again we shall not be going for this. What terminal care has to be taken. Okay, so this is how we finish the ventricular arrhythmias. So the topic related to arrhythmias is over, and now next topic we can go with cardiovascular system. I think only one is remaining, that is related to hyperlipidemia and the anticoagulants one. So we can see what it can be there. I'll suggest you please write on group that which topic you want tomorrow, so that we can think about it. And once we finish cardiovascular, then please go through it. If you have any difficulties you can ask, and then we shall immediately start for whatsoever remaining pharmacological topics are there, CNS and all others, so that we will finish pharmacology in the meanwhile. You will get some time to read these topics in the meanwhile. So I hope you have understood. If you have any difficulties you can definitely write.